Hello, welcome to Chapter 3, The Health System Today. In this chapter, we're going to cover some of today's healthcare system trends. Areas that we're going to focus on are going to be acute care, the hospital types and ownership, ambulatory care, which we compare to acute care volumes, and post-acute care, which is comprised of long-term care, residential care communities, and others, and some other options. Continuing on our trends, we're also going to take a look at behavioral health in the healthcare system today, the healthcare workforce, emerging models of care and payment, financing of healthcare, and a brief touch on the pharmaceutical industry. Several trends are changing the look of our healthcare system, and these result from a combination of forces, including market forces, policy decisions, and the movement away from sporadic individual care toward population health. So in short, we have fewer hospitals and more clinics, fewer primary care physicians, but more specialists. Hospitals are merging with other organizations to become systems, or systems are acquiring hospitals. So in many cases, there may not be an actual acquisition, but rather an agreement for management of the hospital by a larger system. And then furthermore, it's become increasingly untenable for smaller hospitals to survive. And that's because any attempts to mitigate cost increases while improving quality and expanding access to care would have caused the environment to move toward integrated records and emerging payment models that incentivize multiple layers of integration and increased collaboration across traditional clinical boundaries. Acute care hospitals are the backbone of the U.S. healthcare system. You may ask, what is acute care? What does that mean? Well, it's the care that's provided to treat severe trauma or illness for which the patient needs a procedure or medical care as an inpatient. Furthermore, the duration of this kind of care is relatively short, and even in the worst case scenario would not exceed 1 year. Some examples of acute care include heart surgery, joint replacements, and severe illness, such as an extreme case of the flu or some other contagious disease. There are different hospital types and ownerships, and we are going to dive into some of these. Community hospitals, which are the most common type of hospital in the United States. They can be large or small, and they're located in relatively small communities where they provide obstetrics, orthopedics, general surgery, and non-surgical medical care, which is what comprises a large majority of their services. In some cases, cancer care is also part of the community hospital portfolio. But the primary mission for these facilities is providing care for the residents of that community in which they're located. There are also academic medical centers. There's approximately 120 of those and in the United States, and they exist to train physicians. And in addition to that teaching role, they also engage in research that adds to the knowledge about the human body. So they do studies that are responsible for new pharmaceutical compounds that help treat disease, new implantable devices and prosthetics that help keep the body whole, and new methods for treating all the morbidities that can afflict a human being. And then there's also the public or safety net hospitals. These are publicly owned hospitals that exist mostly in major metropolitan areas where they have a tax authority, and that's how they sustain those hospitals. And the cost of owning and operating a hospital anywhere is incredibly overwhelming, and therefore public hospitals are not sustainable in rural areas with a smaller tax base, which is why you see them concentrated in major metropolitan areas. But these hospitals serve as a safety net for their respective communities, meaning that the majority of their patients are either insured through Medicaid or Medicare, or they are uninsured completely. In this graph, there's an illustration of the number of community hospitals by ownership type. Increasingly, various procedures have moved from the inpatient setting to outpatient clinics and surgery centers. Surgical procedures such as cataract removal, arthroscopy of the knee, and a host of other procedures no longer require inpatient care. These procedures may be performed in smaller, more cost-efficient surgery centers and do not require an overnight hospital stay. You can see the number of community hospitals have declined from 1994 to 2015. While at the same time period, you can see the increase of hospital outpatient revenues. So as the number of inpatient procedures has declined and outpatient procedures have increased, the number of places providing outpatient care has also ramped up dramatically over the last 2 decades. Ambulatory surgery centers are frequently freestanding facilities that limit patient stays to less than 24 hours. So the procedures performed there are informally known as day surgeries. And an important distinction is that an ambulatory surgery center, or ASC, is not the same as a hospital outpatient department, which may offer many of the same services but is located within a hospital, and it cares for more medically complex patients. Most ambulatory care takes place in offices staffed by physicians or other healthcare providers. And historically, physicians practice in small groups or on their own as solo practitioners. And through the 1980s and the 1990s, that was the heyday of fee-for-service reimbursement because this arrangement was more economically viable. However, in recent years, hospitals have been acquiring physician practices, and in 2015, hospitals or health systems employed approximately 38% of all practicing physicians. Post-acute care includes long-term acute care facilities for a lot of pulmonary types of conditions, rehabilitation or palliative services that beneficiaries receive after, or in some cases, instead of a stay in an acute care hospital. Long-term care facilities, which are also referred to as nursing homes, serve people who are frequently in very advanced years and declining health. The long-term care facility can provide a wide range of assisted services for people who are unable to perform several of the 6 activities of daily living, or ADLs. The ADLs consist of eating, bathing, dressing, toileting, which involves getting on and off the toilet, transferring, being able to get out of bed or a chair, and continence, which is controlling one's bladder and bowels. Rehabilitation hospitals provide rehabilitation services to patients who may not be able to recover at home. They do not provide surgical procedures, nor are they appropriate settings for someone with a severe medical illness. These highly specialized organizations only provide care for patients who are discharged from an acute care setting, and they supply important physical and occupational therapy to help the patients regain full functioning. Residential care communities are instrumental for patients to assist them with their daily living needs. Things like shopping, cooking, managing medications, laundry, housework, transportation. They are more independent than a long-term care facility, and they may include more than one form of care to allow for continuity. Other post-acute care options include home health agencies, adult daycare centers, and hospice, as many patients receive care at home or in day centers which are designed to serve the elderly. These other options fill the gaps in the care continuum by providing alternative locations or by providing a less intensive kind of care or support. Behavioral health care is the most expensive category of disease. Behavioral health issues include substance abuse, mental disorders, Alzheimer's disease, and other dementias. A patient's primary care provider is the ideal first contact for obtaining care for behavioral health concerns. And while behavioral health care historically has been administered on an inpatient basis, care may be more effective when employing an outpatient or ambulatory options. Now, despite the cost of behavioral health disease, the overall projected costs for combined mental health and substance abuse are expected to lag behind other healthcare spending through 2021 and beyond. And that's not to say that behavioral health care costs will not increase. They will increase more slowly, and they will become a smaller portion of the national health expenditure over time. And the reason for that is many drugs that are used to treat mental illness are losing patent protection and are being replaced with less costly generic drugs. And then also, most states have closed many of its psychiatric hospitals, and that is also contributing to a slower spending growth in behavioral health. The healthcare workforce is where we will discuss the adequate supply and scope of practice for physicians, nurses, physician assistants, and nurse practitioners. Between 2000 and 2016, the number of physicians in the United States grew at a rate of 7.76%. Meanwhile, the rate of population growth for those same years was 14.8%, which suggests a serious shortage of physicians in the future. Nurses, on the other hand, climbed from approximately 2.19 million in 2000 to 2.85 million in 2016. And based on existing supply, nursing education trends, and the expected demand for nursing services, there's a projection of a surplus of nurses by the year 2030. Physician assistants, PAs, and nurse practitioners, NPs, have become increasingly important in recent decades. They are commonly referred to as extenders or mid-levels, so you may hear those terms. But PAs and NPs provide an important array of caregiving services, including ordering labs, imaging, which helps provide the patient and the physician a preliminary diagnosis. They also frequently fulfill duties formerly performed by physicians, thereby extending the physician's practice, hence the moniker extender. Together, PAs and NPs provide care that falls between what an RN is licensed to do and what a physician does. So to be clear, the PA and an NP occupy different roles. A PA is usually required to practice under the direct supervision of a physician, whereas a nurse practitioner can, depending on their training, be a nurse anesthetist, a nurse midwife, or an NP. An NP can coordinate patient care and may provide primary and specialty health care. Some of the emerging models of care and payment include clinical integration, accountable care organizations, Medicare shared savings programs, and bundled payments. So remember earlier, we pointed out that three important trends in healthcare. First, the number of hospitals is declining, either through closure or through merger and consolidation of licenses. Second, along with that consolidation, the number of hospitals that are considered part of a system has increased in recent decades. And then finally, we saw that hospital inpatient revenue is declining while outpatient revenue is increasing. So these are the trends that are evidence of new emerging models of care. One of the things, as we look at clinical integration, it notably comes from the federal government in the form of Medicare, where there's been initiation of new payment models that are intended to encourage better quality of care while reducing the volume of care. Often referred to as pay for performance, it is combined with newer and better technology. That's where we get the term clinical integration. Clinical integration is simply the coordinated delivery of patient care by a team across conditions, providers, settings, and time to achieve high quality care. It's best effectuated by a common electronic health record to keep all of the providers informed. As far as accountable care organizations, that is where clinical integration was truly put into practice. The accountable care organizations were authorized under the Affordable Care Act, and they were created to encourage the seamless exchange of information among providers by making all of them jointly responsible for the care of a Medicare patient. And then the providers are all financially motivated to cooperate because of the Medicare Shared Savings Program, or MSSP, which was also created by the ACA. Shared savings means that if the ACO, Accountable Care Organization, can improve the health status of a population while also saving money for the payer, in this case Medicare, the providers share in the financial benefit. And then frequently this process involves the use of bundled payment mechanisms. Bundled payment is simply payment to providers that are based on expected costs for clinically defined episodes of care. The financing of healthcare, you can see this trend moving from fee-for-service to shifting the risk from the payer to the provider, ultimately to pay for performance. We're going to get into the financing of healthcare much deeper in Chapter 11, but for now we will discuss certain elements which are necessary in examining the structure of our healthcare system. How healthcare is financed and how payment mechanisms are structured influences how and where care is delivered. Now, some would say that in this era of reform, we are moving away from traditional fee-for-service, in which the insurance company pays the provider an agreed-upon fee for the specific service provided. The claim would be that there's concern that this form of payment encourages patients and providers to overutilize the system, meaning that those of us who pay insurance premiums and who pay taxes to support Medicare and Medicaid, which is all of us, we are ultimately paying for unnecessary medical services performed on patients who do not need them. I will say that the reality is that even though there is a lot of talk about pay for performance, and there is a small holdback and some requirements for providers participating with Medicare to be engaged in some quality programs. By and large, when you look at reimbursement, the needle has not shifted much, if at all, from fee-for-service. Now, does that mean that that will always be that way? No, but for the amount of chatter that there is surrounding pay for performance, the evidence for what is in reality happening still is predominantly fee-for-service. As it relates to the pharmaceutical industry, it is the fastest growing segment of healthcare spending, and it is ongoing. The cost increases are attributable to several factors. First, utilization of prescription drugs continues to increase, and second, New and expensive drugs, mainly for cancer treatment, have now arrived on the market. And then third, the length of patents on brand name drugs makes it difficult to bring a generic equivalent to market. So those are some of the reasons for that. Despite that, it is still third behind hospitals and physician care as it relates to spending. And there are efforts to constrain some of these pharmaceutical costs, which has led to the advent of the pharmacy benefit manager, or PBM, and that is essentially a third party that is used by insurers and managed care companies to increase the efficiency of providing drugs to the insured consumer. So they excel when they are able to get manufacturer rebates or encourage the use of generic drugs whenever possible. So in conclusion, our healthcare system continues to evolve. We know that the U.S. healthcare system is large and complex, and we also know that it is constantly evolving. We know that today's healthcare is grounded in science and is increasingly reliant on technology. The system continues to be challenged by issues of cost, quality, and access, and new organizational structures and payment mechanisms aim to improve quality while constraining continued cost increases. We've also seen that care continues to move from inpatient settings to ambulatory facilities, and that advanced pharmaceuticals have helped replace some of the rising hospital costs. As the population ages, there will be an increasing demand for a variety of long-term care services, and the post-acute care industry is poised for growth, ready with a variety of organizations to serve the needs of baby boomers as they retire in record numbers. New types of providers will extend primary and specialty care, while electronic medical records facilitate the sharing of information among various providers. As you will see in the chapters ahead, that the relatively new focus on team-oriented care and an emphasis on patient-centeredness while integrating provider roles more closely is the future model of care that is beginning right now. The confluence of new technology, better drugs, new kinds of providers, and new ways of working together give hope for a system to address the ongoing challenges of cost, quality, and access.